Our next speaker is Viet Do, Dr. Viet Do. He is a radiation oncologist, the Director of Services at Liverpool Cancer Therapy Centre, a senior clinical lecturer at the UNSW. I probably said that wrong. He is skilled at brachytherapy and image-guided radiotherapy in the management of gynae cancers. Dr. Do is an ANZGOG member and he is here to present our session, What is the role of radiotherapy in a clinical trial, both in isolation and with chemo? Please welcome him to the stage.
Thank you very much, Karen, for your kind introduction. Let me just start by saying how humble I am to see how Wanda react to the absence of her slide. You only see that in patients. Had it been the doctors, we would have thrown the town and gone home. You know, I always in awe at the strength with which you as our patient and carer, that mental and physical strength going through the treatment, then have that strength to expose the vulnerability, to share your experience, and coming to organization like ANZGOG to help us. I thank you for that. We are different clinicians, different physicians of different craft group. We are scientists, but we speak with one voice at ANZGOG. And that voice is how we could have the best available research that are available for women in Australia, in New Zealand that are affected by cancer. And on that note, I would like to share with you a little bit about radiation therapy and the clinical trial in ANZGOG. So what I would like to go through today is, what is radiation therapy? Is it an effective, is it an inexpensive treatment that we should consider? Should radiation therapy be considered in a setting of clinical trial? What have we done at ANZGOG? Where we would like to go in the future. And this definition are taken now from radiation oncology targeting cancer, which is a body group from our college to try to engage with our GP, primary care physician, with our patient to say that this is in Australia, we are very lucky to have freely available radiation therapy in all public hospitals, most public hospitals. So radiation therapy, or radiotherapy, or RT, as we call it, we use radiation such as high-energy X-ray, gamma rays, electron beams to kill or damage cancer cells and stop them from growing and multiplying. Radiation therapy is safe and it is effective. It involves the control application of radiation to cancer anywhere in the body. And there is technological advantage that allows to scope the dose where we don't want to give. And also, we also know that the cancerous cells are almost always more susceptible to radiation than healthy and non-cancerous cells. And therefore, if you give radiation over a number of days with 24 hours in between, your normal healthy cell can have time to recover. Let me spend a minute or two to try to convince you that radiation therapy is a very cost-effective cancer treatment. Around 50% of our cancer in their journey through the cancer treatment will probably come across our radiation oncologist and be advised about receiving radiation therapy, and that's the optimal utilization rate. It differs for different cancer. In cervical cancer, for instance, about 2/3 of our women would have received radiation therapy as part of that treatment, and a lot of our women would actually have a prolongation in life due to the fact that they have radiation therapy. Let's talk about cost. Cost is quite complicated and probably a difficult thing to talk about, because there is the initial cost of set up the machine to procure the linear accelerator for the planning and the ongoing operational costs. And cost is different in low-income country versus high-income country like Australia. So the upfront cost, say in the States or in Australia, might be about $800 or about 1,200 Australian dollars. But the ongoing operation and cost in US, $233 or in Australia about $330 for each treatment that patient received. So may I just say that probably that not very expensive, and it is a very effective treatment. So why should we evaluate radiation therapy in clinical trial? You would have hopefully hear or advised by your GP, by your physician, that radiation had changed significantly, both technologically and our ability to deliver the dose where it needs to do. Traditionally, when we want to treat the pelvis in the old days, we would have delivered what we call a box technique, bring in 25% of the dose from the front, the back, and either side, equal distribution, without much regard for the small bowel, for the bones. But modern radiation therapy is very different. We have the ability to select out what we want to treat and select out what we do not want to treat. So with modern technique like intensity modulated radiation therapy or volumetric arc treatment, we can select out not treating the small bowel, not treating the bladder, not treating the rectum, preserve the bone marrow for the time when you need to use it. And that's the beauty. But you can't just bring it out in practice. And I'm glad to share with you that there is a trial which has been published to say that the modern technique of radiation therapy has led to a reduction in side effects, and that's fantastic. Another new technique that patient might have heard is stereotactic body radiation therapy, whereby we deliver very high dose of precise radiation therapy in a small number of treatment, and that's very efficacious, say for lung cancer, that patient cannot go through with the surgery. In women with cancer, that's called internal treatment or brachytherapy, whereby we give very high dose inside the tumor itself. So those are the things that will be ongoing investigated. What we have achieved, I guess, in ANZGOG in terms of clinical trial, and you may have heard about the Outback already. And most of these trials that we conducted in ANZGOG always come from we asking the right question. And the question we asked for PORTAKE 3, because we noted that in our women with slightly advanced cancer of the uterus, there is a very high chance that with standard radiation alone, those women will actually have disease coming back outside the pelvis. So the question that the PORTAKE pose is, if we bring in the additional of chemotherapy on top of radiation therapy, would it make a difference? And I will share that with you. The same with Outback. Outback is a trial we try to address very similar question. We know that the combination of chemo and radiation therapy for intact cervix cancer work quite well. But we also know that maybe up to 1 in 3 women after those treatments still have cancer coming back. And that's mostly, again, outside the field of radiation. So is the additional of chemotherapy, would it make a difference? And we're still waiting the result for Outback. But for the PORTAKE, I think what we know is in the PORTAKE, patient who on what we call stage 3, more advanced cancer, when you add chemotherapy, those women tend to not see the cancer for a long period of time. And we hope that with long enough sort of follow-up, you will see that those very women will actually live longer as the effect of combination of chemo and radiation therapy. I came from Vietnam in the mid-1980, and there's a group that I like to listen to called the Divinals. And there's a fine line between pleasure and pain. And the pain of the treatment, or with any gain that we have, there is also that side of suffering. And that is, we see that in the side effects that our women going through with the trial experience. And you can see that patient having the combined treatment of chemo, radiation therapy during the time of treatment experience more side effects. But the good news is by the time the long-term follow-up of 2 to 3 years, it's all equal. So I think that is a message that that we need to give it out is that yes, there will be a difficult time. I always tell my patient that the quality of life during treatment is not the same, but we hope to bring you back where you were before. And I think that's very important for us to do that. So we look at it, this is just another way to look at it, is in terms of global quality of life. We can see that during the time of treatment is actually not as good as when you have both chemo and radiation therapy. And the effect of the combined treatment on the low blood count, on diarrhea, fatigue, those tend to recover by 12 months. But what we noted in our study is the effect of numbness and tingling may last a little bit longer for a small number of our patients. In Australia, we never take on an international study and just do that for the sake of doing it. We always put in an Aussie slang. And what we do for PROTECT 3 is we do two different sub-studies. One is we call benchmarking. The beauty of benchmarking is that if you benchmark, i.e. if you have the same way of deliver the treatment through the concept of trial, then the kind of treatment that you deliver at the Centre of Excellence in Peter Mac is the same anywhere else in Australia. And we find in benchmarking, that's what we can achieve in Australia. So we conduct this and we find that after the benchmarking, the quality with which we deliver our treatment is highly uniform and of very good quality. In fact, even better compared to our international counterpart because we have done the benchmarking exercise. The other sub-study that we do is because center to everything that we do at ANZGOG or in our daily practice is you, our patient. And we ask the question because these are the questions got to be asked. As we know, there is gain and there might be challenges. So we ask the question among our patients who, about 83 of our patients who completed a trade-off questionnaire about whether or not they would be willing to go through chemotherapy and what would they willing to accept. And what we find is that over 50% of our patients judge that one extra year of life or a extra 5% survival rate would make the chemotherapy worthwhile. And we asked that among our physicians. And there's some similarity, is that the doctor would say, yeah, if you could make me live 1 year longer, I would take chemotherapy. But we push it a bit. We say that we might want to see a 10% survival rate. So when you compare, say, our patient with breast cancer, that is a little bit smaller. So our patient with breast cancer willing to take chemotherapy at a slightly smaller rate of gain. So I thought that was very interesting and that very much Australian sub-study on the PROTECT 3. Where do I think the future of radiation therapy in terms of clinical trial? I think it's going to be two-way. One is that we will use what we have in our hands, the modern technology, in order to reduce side effects of radiation therapy, or when it's possible to actually take the radiation out of the equation to avoid side effects, and I will discuss that with you briefly. The second way that I think where we're going to go is use radiation therapy in combination with other systemic treatment like chemotherapy, immunotherapy, in order to prolong our patient life. So this is one of those studies. Again, we collaborate with our Dutch counterpart in a study. We hope to collaborate in a PROTECT 4A, and it is a randomized trial that in a group of women not as high risk as a PROTECT 3. So this is what we call intermediate high risk, whereby the standard treatment is vaginal vault brachytherapy, internal treatment. We argue that there is a subgroup of patients in that do not need the radiation therapy. And what we would like to do is through a panel of molecular profiling to identify exactly who those women are and say, look, you're very good. You do not need radiation therapy. And at the same time identify the very same women in that group that standardly would have been given vaginal wall brachytherapy and say, that might not be enough for you. We might need to give you a little bit more. And that is what we call molecular profile based, and we are still waiting for our grant to be assessed, but we really hope to be able to bring it in Australia, because I think that would be fantastic. The other thing that sometimes we like to look at is we know that despite all the effort, some of our women at some stage will come to a time when they have to face with the advanced, incurable aspect of the disease, with bleeding, with discharge, with pain, with obstruction. And there is a question of palliative treatment to try to improve the symptoms. And you could, as you can see on those pictures, I just used a picture of a cancer in the bone to illustrate 2 points. The first is that if you use a portal of front and back to give radiation therapy, like the one on the upper right versus the lower one, you achieve the same endpoint. But what the difference is that the one in the lower part is very precise, and it saves all of the bowel from going through with radiation therapy. So we want to ask that very simple question. If we use precise modern radiation therapy to palliate symptoms, and if we find that probably the way that we could get out of that is through patient report outcome. You will tell us what is the right way that we go about doing things. Let me share with you another 2 slides before I'm finishing. This is a report from the US looking at the characteristic of radiation therapy trials versus other cancer trials for a period of 10 years between 2007 to 2017. If you have 100 cancer trials, only about 5% are radiation therapy trials. And the industry is less likely to support radiation therapy trial, probably is not sexy enough. And I guess the other thing is the fact that radiation trial, because the technology is coming out too fast, and therefore the trials sometimes tend to not finishing in time, or not complete it in time. And that experience is actually similarly shared across the Atlantic. In Europe, they face exactly the same problem, but they're thinking of a few possible solutions. And the first is probably use the academic group to lobby the government funding and mentor the next generation, so that we have a succession plan of our younger generation will continue to do the trial. And we will continue to collaborate like the way we do in Outback, like the way we do in Portic 3, combined with chemo, immunotherapy, in order to make things better for our patient. And that would bring me to my conclusion, is that yes, I think we have made major contribution at ANZGOG in developing trials of radiation therapy sequencing with chemotherapy to improve cancer outcome and minimize toxicity. In the future, we hope to continue to ask the right question, and the right question have to have advice from you. To lobby our government for funding, to collaborate with our key stakeholders to facilitate the best high-quality evidence-based radiation therapy. I thank you for your time.
Does anyone have any questions for Dr. Do? With regards, yes?
Just been chatting about CyberKnife. We've been chatting about CyberKnife.
Yeah.
What is that?
I think CyberKnife is probably one of the modern technique that we use, in particular useful to treat CNS tumor, brain tumor. That work, CyberKnife, I guess, use the ability of radiation therapy and the robotic arm to actually bring the radiation to exactly where we want to do, using multiple gamma source. It is available at the moment, I believe, only in the private center in Sydney. It's not cheap. Similar to my discussion with you before, sometime in radiation therapy, we have not a good habit of bringing out new technology and have not, say, compare them with the best of our modern technology treatment. So using the normal linear accelerator in a public facility across the country, using the exact track to identify where the tumor is, with our modern treatment, we can similarly achieve probably the same result. But that has not been answered through a clinical trial. That's exactly why we need to have clinical trial. Sometimes we have the notion that if we pay money, 10,000, 20,000, we're going to have better treatment. That might not be true in the case of radiation therapy. Thank you very much for your time. Much appreciated.